Hi, my name is Angie Hotz, and I am doing a video of my skills scenario essay. Couple reasons why I wanted to do a video. I am writing a lot of papers and didn't want to write another paper. That's not like the main thing. I actually don't mind writing papers, but my brain has just been in that mode for so long that it's actually kind of tough. It's kind of nice to talk through these things. So, like, that leads me to my second reason why I think that actually narrating and talking about what I would do is making me remember and think about the scenario in a different way than if I was just writing it down. So, I chose to do scenario number 1. The main reason is that I already have a preceptor, and the things in the scenario are things that I'm doing already. I'm doing them currently and perfecting those skills. I've been with my preceptor since June. I have birth assisted with her a few times. Her current birth assistant is who trained me to be a birth assistant, and then I was her backup when the current birth assistant, April, when she was out of town, I backed her up a couple of times. And so that's why I started working with my preceptor. And then when I became a student, now I'm in that role. So I've been to many births, not many, maybe a dozen births with her. So probably about a dozen births or so. Anyways, in clinic, I do clinic 3 days a week, and then births. I am taking vitals for mom and listening to fetal heart tones, as well as at births. I am doing some charting until the birth assistant gets there, and then the birth assistant charts. But sometimes the birth assistant misses it. Like, we were at births over the last couple of weeks. 2 of them, the babies came really fast, and the birth assistant missed it. And so the midwife and I, my preceptor and I, were doing the charting. So I'm getting practice doing that. I'm just going to jump into the scenario. So I have it typed out. I have the scenario typed out on my laptop, and I have that open. And then I just wrote down kind of some little blurbs. I didn't really think about it for a long time or anything. I just started kind of going over the scenario in my mind, and I just typed out a few things that I wanted to make sure and cover. Okay, so Sophia is in active labor when you arrive. Your preceptor asks you to provide some labor support and take vital signs in the next 10 minutes, charting everything as you go while she sets up her birth tub. So when we arrive, when we walk in, set down our stuff, kind of look around, see who's there, say hello to everyone, and then we go right to the bathroom or to the kitchen and wash our hands. That's what we would do first. And then especially if the preceptor had already been there and kind of started setting things up, which it sounds like that's the case from this scenario, that she got there first and was kind of settling in and getting ready to set up the birth tub. It sounds like maybe she hasn't done. I'm going to assume that from what this says, that the initial vital signs have not been taken, and that's what I will be doing. So I will have the chart, and I will chart that I arrived, what time I arrived, and then start having conversations with Sophia, getting an idea as to what her contractions are doing, how she's coping, how far apart they are, chat a little bit with the support people that are in the room. I have been a doula for a few years and have been to quite a few births, and I'm comfortable in that role. And so I feel like doing that labor support it's fascinating because it's so helpful for the mom and it's so helpful for the support people in the room. But it's also gathering information too. So, checking on her, how are you coping? How are you feeling in this position? Have you gotten up to go to the bathroom recently? Like, how'd you sleep last night? Are you eating? Have you had a snack? Can I get you a snack? Just sort of some probing things that kind of get an idea as to what's going on, but also to where I can get an idea as to what I can do for her to make her more comfortable. So I would be asking those questions, kind of getting an idea as to how far apart the contractions are. At the same time, probably, in amongst this conversation I'm having to, start the dialogue going and get the rapport going with the people in the room. I'm going to be finding the blood pressure cuff and the stethoscope and the thermometer, the Doppler, the gel for the Doppler, and a washcloth or something to, wipe the gel away. And then I would be chatting with her as well about kind of what to expect. We more than likely would have talked about it at the home visit, kind of what to expect when we arrive, but I would reiterate that and say, we would like to go ahead and do the full set of vitals on you. And we do that every 4 hours. And this is the listen that we do on baby that's a little bit longer. We listen for 5 to 10 minutes. And to get a baseline to see what baby's doing and how baby's tolerating everything, and just, check in and get a baseline on everyone. And then let her know that her vitals will be done every 4 hours. And then after this long listen for the baby, then we would check in with baby every half an hour for a minute. But at that point, she can, through all of this, really, she can be wherever she needs to be, and reassuring her that we'll do the things in between contractions. And that's kind of why I would want to be chatting and asking her what her contractions are doing and kind of getting an idea about that. So that way I can gauge how much time in between contractions I have to do these things without being too disruptive. So I would start with her vitals first. I would, if her contractions are coming really close together, then I would put the blood pressure cuff on, wait for her to have a contraction, and then take blood pressure. And then maybe after a contraction again, depending on how fast they're coming, then take her pulse, and then her temperature. If they're a little bit farther apart, if they're, 4 or 5 minutes, even 3 to 4 minutes apart, I can probably get all of that stuff done in between. I would chart what I'm finding. So I would chart blood pressure, I would chart the pulse, I would chart the temperature, I would chart position that she's in. If I hadn't done that already, I think I had said that maybe I was doing that when I said that I had arrived. But I would chart, is she on the couch? Is she, whatever it is that she's doing. If she had said anything in our conversation that I think needed to be charted, like maybe she's saying it's too much, or maybe she's saying that she's feeling a lot of pressure in her bottom, I might chart that and say either client reports and then say it, or even use quotation marks if she's saying things that need to be put down like that. Like, I'm feeling a lot of pressure in my bottom, I might put that in quotation marks. So after I'm done with her vitals, I would reassure her again that she can be in whatever position she wants to be. Like, just do her thing, cope however she needs to, and then go ahead and listen to baby. Listen to baby for the full 5 minutes for sure, but if sometimes it's longer. It depends on if I'm getting the reading that I need to get and listening and hearing what I need to hear. So I would put, when I chart fetal heart tones, I would put FHT, and then an X, so by, and then however long I listened. I might even put that this is the initial baseline fetal heart tones. I would note how many contractions she had while I was listening. I would note whether or not there were accelerations, decelerations, and if I noticed baby's movement, which typically do, they are wiggly and I have to kind of chase them down. And I would also kind of in our conversation and when I'm doing fetal heart tones, asking, how are you feeling baby moving? Tell me about that. Tell me what you're experiencing and what's baby feeling like. And then I would chart that too. And it's usually, positive fetal movement. So yeah, and then as soon as I'm done with that, I'm going to wipe the goo off of her belly, and then probably by then we're going to be thinking about, getting her in the tub since the tub's being set up. Yeah, once that initial set of vitals is done, she may or may not want an exam. Most of the time my preceptor will offer that to her. But not always. It depends on what we find when we arrive. Like, if things are really active and she's just moving right along, and if through their conversation they decide that it's not necessary, then they don't. But at that point, if they do decide to do that, they would do the vaginal exam, usually on the bed, and I would chart what the midwife says she finds, and we would go from there. So I think that's everything. I don't know if I mentioned it or not. Like, I've practiced saying this video many times now, so it's hard to remember what I've said in my practicing. But my midwife uses Client Care app for prenatal visits, but we paper chart for birth and that immediate postpartum. So we would be using the labor and the labor flow chart. They're the Moz charts. They're a little bit modified just to have the stuff that my preceptor has on there, but they're very similar. Yeah, I think that covers it. So I think I'm going to stop now and go from there. So kind of as a side note, I think that I'm going to go ahead and go through the other skill scenarios just for practice, for when we do need to do this for assessment. I will go through and either make another video just to practice, or I will write the papers and write out the things that I would do. Because like I said, I feel confident that I would know the things if they were in front of me, or if I was digging around in bags or the supply closet or whatever to set up a birth kit or to set up an IV. But again, I'm still learning those things, either with my preceptor or I'm in IV skills now. And so I'm learning those things. And but I do feel a little bit more comfortable with the first scenario to actually explain what I'm doing. So, all right, I hope that covered everything, and I'll see you guys later.